Hello students, welcome to EPG Pathshala. I am Dr. Renu Tyagi from Department of Anthropology, University of Delhi. Today I am going to speak on the module Reproductive Survey from the paper Research Method and Fieldwork. The learning objective of the subject include the discussion, definition and scope of the reproductive health, to understand the indicators of reproductive health and to study the obstetric history taking. Now let's discuss about the definition and scope of the reproductive health. Reproductive health is a state of complete physical, mental and social well-being and not merely the absence of the disease or infirmity in all matters relating to the reproductive system and to its function and processes according to the UNO 1994. This concept assumes that people have the ability of satisfying and safe sex and they have the capability for reproduction and choice to decide. The scope of reproductive health cover from the conception to old age and emphasizes maintenance of the good health and prevention and treatment of the illness according to World Health Organization given in 2006. Now let's see the scope of the reproductive health. The reproductive health care involves information, education, communication, services to the adolescents, discouraging the practices like the genital mutilation, prevention and management of the gender violence, prevention and treatment of obstetric complications and safe termination of unwanted pregnancies, promoting safe motherhood, and education and provision of clinical services for family planning according to WHO 2006. Economic status, gender, education and social statuses are found to be the predictors in the use and gaining the access to the reproductive health care in India according to Seneving 2013. Now let's see the various indicators of the reproductive health. International agencies consented for the 17 indicators to monitor the reproductive health goals. These indicators comprise indicators of the outcome, access and use of the healthcare system. These indicators are described in the next forthcoming section of this module. The total fertility rate is expressed per 1,000 women. Data on the birth count can be collected from the vital registrations and information on women of reproductive age from censuses. Survey results provide data on fertility and trends. Survey data suffer from the response bias and age misclassification. To prevent age misclassification and sampling error, in the calculation of TFR, birth preceding 36 months is considered. Presentation of the sampling error and confidence interval along with the TFR is advocated. As age-specific fertility rate, that is ASFR, shown to be sensitive to the changes in fertility, collecting of the ASFR data by age, socioeconomic status and residence is advised. Total fertility rate, that is TFR, is a good indicator of population momentum and poor physical reproductive health. It is independent of age structure. It is also being used as surrogate marker to assess the family planning services. Now let's see the contraceptive prevalence. The contraceptive prevalence is the percentage of women of the reproductive age who are using or whose partner is using a contraceptive at a given point in time. In India, 98% of the women and 99% of the men in the age group of 15 to 49 years of age reported awareness on one or the more method of contraception as per family welfare statistics given by the Government of India in 2011. The contraceptive methods are two types, that is clinical and supply or the modern method, and non-supply, that is traditional methods. Clinical and supply or the modern methods consist of the female and the male sterilization, intrauterine devices, that is IUDs, hormonal method, that is oral pills, injectables and hormone releasing implants, skin patches and vaginal rings, condoms and vaginal barrier methods, that is diaphragm, cervical cap and spermicidal foams, jellies, creams and sponges. The traditional method comprised the rhythms, withdrawal, abstinence and lactation amenorrhea. Now let's have a look at the data on the prevalence of the contraceptive use, which is collected using the population-based surveys, small-scale or focused surveys. The family planning program records can be helpful in reporting the trends and details of the usage. The drawback of this type of information include double counting of the user, poor quality of the data and data manipulation. Interview methods are used to collect the data on the contraceptive prevalence involving the married and couple on consensual union where culture permits. Documentation of the age-wise usage of the contraceptives may be useful to know the information on type of contraceptives and by different age groups. The next indicator is the maternal mortality ratio. Maternal mortality ratio is the number of maternal death per 1 lakh live births. Maternal death is the death of a woman while pregnant or within 42 days of the termination of the pregnancy, irrespective of the duration and the site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but other than from the accidental or incidental causes, that is ICDs. Direct obstetric death refers to the maternal death resulting from the obstetric complication of the pregnant state, that is pregnancy, labor and puerperium, from interventions, omissions or incorrect treatment or from a chain of events resulting from any of the above mentioned or earlier mentioned ICDs. Late maternal death is defined as the death of a woman from direct or the indirect cause more than 42 days but less than 1 year after termination of the pregnancy. Now let's have a look at vital registration, health facility based data and population based surveys or surveillance are the sources of the data for maternal mortality ratio. The maternal mortality is underreported in vital registration due to sudden death, failure of the relatives to incur time or travel cost to register the death, feeling of blame or culpability among the relatives to report the death, and misclassification of the deaths. Data from health facility may not be qualitative because of the selective nature, inaccuracy of the registers and case sheets, omission of the data and inaccessibility. The cross-sectional household surveys, continuous population surveillance data, hospitals and health center records and key informants are another source of information, but they require larger sample size, time and they are cost intensive too. Sisterhood method involves asking the questions to the sisters about the survival of their sister and women at risk for each household. Confidential surveys provide information on number of maternal deaths, causes, avoidable factors and guidelines for improving the clinical outcomes. This type of survey works better where the good infrastructure is available to collect the information. In view of the cost-intensive nature, the data is collected every 5 to 10 years. Disaggregation of the data into urban-rural is not appropriate unless there is a sufficient evidence on the quality of the data. The interpretation of the data should be done taking into the variation under consideration in the estimation. The next indicator is the antenatal care coverage. The proportion of the pregnant women attended at least once during their pregnancy by the skilled health personnel for reason relating to the pregnancy. The skilled health attendant or skilled attendant is referred to an accredited health professional or midwife, doctor or nurse who has been educated and trained in proficiency in the skills needed to manage the normal or uncomplicated pregnancies, childbirth and the immediate postnatal period, and in the identification, management and referral of the complication in women and the newborn according to World Health Organization. Live birth may be defined as the birth of a fetus after 22 weeks gestation or weighing 500 gram or more that shows the sign of the life, that is breathing, cord pulsation or with audible heartbeat. The sources for the data collection for this indicator are the health services data are useful when utilization is high. The disadvantages of the health services data is double counting, incomplete or missing record and poor quality data according to Graham et al. In 1996 and according to the WHO stated in 1997. Household service data is routine source, involves public sector only and its utilization is low and introduce selection bias in the data. Household surveys are important source of information and report counts, confidence interval, trends and differentials. This indicator is disaggregated by the place of delivery, type of skilled health personnel, urban, rural and socio-economic status. This indicator measures health systems functioning and possibility of adequate coverage of deliveries. Now let's have a look at the availability of the basic essential obstetric care, that is BEOC, and availability of the comprehensive essential obstetric care, that is CEOC. These indicators are related to the availability of the essential obstetric care. They are recommended as the assessment tools to gauge the national and the global progress in reduction of maternal mortality. A basic essential obstetric care, that is BEOC facility, is the one that performed all of the 6 services known as the signal services at least once in the previous 3 months, like administration of the parenteral antibiotics, oxytocics and anticonvulsants, manual removal of the placenta, removal of the retained products, for example, manual vacuum aspirations, and assisted vaginal delivery, that is vacuum extraction or forceps, according to the UNICEF 1997. The data source of this indicator include all public and private facilities and population census data. The availability of CEOC facilities disaggregated into rural and urban areas. These indicators raise the awareness on the need of availability of CEOC for the management of life-threatening obstetric complications and reduce the maternal mortality. Wherever private primary care is involved, CEOC then BEOC care can be estimated accurately. The next indicator is the perinatal mortality rate, is defined as the number of deaths of fetuses weighing at least 500 gram or when birth weight is unavailable after 22 completed weeks of gestation or with a crown heel length of 25 cm or more, plus the number of early neonatal deaths per 1000 total births. Live birth refers to the complete expulsion or extraction from its mother of a product of conception, irrespective of the duration of the pregnancy, which after such separation breathes or show any other evidence of the life, such as beating of the heart, pulsation of the umbilical cord or defining movement of the voluntary muscles, whether or not the umbilical cord has been cut or the placenta is attached. Each product of such a birth is considered live born. Fetal death is the death prior to the complete expulsion or extraction from its mother of a product of conception. Irrespective of the duration of the pregnancy, the death is indicated by the fact that after such separation of the fetus doesn't breathe or show any signs of life. The duration of the gestation is counted from the first day of the last menstrual period and expressed in either completed days or completed weeks. Gestational age and body length can be of use when information on birth weight is not available. Vital registrations, birth notification, health facility based data, population based surveys, censuses and confidential inquiries are the source of information of this indicator. Confidential inquiries collect data on the cause of the death. Data on the live births and stillbirth must be included with gestational age or birth weight and time of death for the live born infants. A set of questions on pregnancy history and information on the number and age at death of live or stillborn infants are used to calculate the perinatal mortality in the surveys. Mother's socioeconomic status, place of birth, birth attendant, private public provider, single and multiple births may be useful to know the influence of the socioeconomic status on the perinatal mortality and utilization of the health services. It also serves as alternative sensitive measure of maternal health. It is not a useful indicator to monitor the effectiveness of interventions targeted to reduce either stillbirths or neonatal deaths according to WHO stated in 2006. Now let's have a look at the prevalence of low birth weight in India. The proportion of the live born babies who weigh less than 2500 grams is considered as the low birth weight. The birth weight is the first weight of the infant obtained after the birth as per the ICDs. For live births, the birth weight should preferably be measured within the first hour of the life with measurement accuracy of at least 10 gram and a correct reading technique. The source of the data of this indicator are service-based data and population-based surveys. Birth weight is recorded in hospitals and presented as percentage of the infant born with a birth weight weighing less than 2500 gram or in the birth weight groupings according to the World Health Organization 2006. This data may not be representative of the population and should be used with caution. In some surveys, mothers' assessed size is taken into consideration and this may not permit the estimation of the low birth weight. The low birth weight should be recorded throughout the year rather than at one point of time in view of the evidences of the seasonal variation in the rates of low birth weight. Rates of the low birth weight have been shown to depend on the food availability, epidemics and social and other causes. Low birth weight is strongly associated with the perinatal mortality and morbidity, infant mortality, disability and disease in the later life. Low birth weight is a strong predictor of an individual's baby's survival, an important measure of the infant health and a surrogate measure of the infant morbidity and risk of mortality in the population. Adequate measures are taken to ensure the accurate readings. Now let's see the prevalence of positive syphilis serology in pregnant women. The proportion of the pregnant women aged 15 to 24 years attending the antenatal clinics with a positive serology for syphilis. The source of the data of this indicator include sentinel surveillance approaches and community-based surveys as given by WHO in different years, namely 1999, 2000 and 2002. Pregnant women are tested for the syphilis during antenatal care. Though data is useful, the quality of reporting and testing is questionable. Samples may not be representative of all the pregnant women. Syphilis serology may not correlate with the sexually transmitted infection, that is STI prevalence. Community-based survey require large sample. Voluntary testing introduces participation bias in the data. Data specific for the age, residence, socioeconomic status and parity may be of use than the total prevalence. It is a surrogate indicator to assess the burden of the STI and serve as a measure to monitor the progress towards reducing the burden of STI. Infertile women and non-pregnant women are excluded in the data. The data may not represent the overall population. The proxy value of this indicator is estimating STI prevalence is limited. Now let's have a look at the prevalence of anemia among the women of the reproductive age. Refer to all women aged 15 to 49 years. Anemia is a disorder characterized by a blood hemoglobin concentration lower than the defined normal level and is usually associated with a decrease in the circulating mass of red blood cell, that is RBCs. Nutritional anemia include iron, folate and vitamin B12 deficiencies. Anemia can cause death because of the heart failure, shock or infection due to impaired capacity to support the vital functions. Health facilities and population-based surveys are the source of information for this indicator. Syne-methyl-globulin is considered as the gold standard for estimation of the hemoglobin concentration according to Sari et al. In 2001. HOMO-Q method clinical examination hemoglobin color scales are also used for screening anemia in surveys. This indicator is useful to screen the women with iron deficiency and can be used as a surrogate marker for assessing the nutritional status and as a direct measure to find the health status. Now let's have a look at the percentage of obstetric and gynecological admission owing to abortions. The proportion of admissions for the spontaneous or induced abortion related complication to service delivery points providing inpatient obstetric and gynecological services among all admission except those for planned termination of the pregnancy. Abortion related complications occur due to spontaneous or induced abortion. Induced abortion may be attempted by the women themselves, that is self-induced, by the clandestine, that is illegal providers, or by the licensed providers offering. Abortion is the termination of a pregnancy before the fetus has attained viability, that is, become capable of independent extrauterine life. Induced abortion is the deliberate termination of a pregnancy before the fetus has attained viability, that is, become capable of independent extrauterine life. Spontaneous abortion is defined as the spontaneous termination of a pregnancy before the fetus has attained viability, that is, becoming capable of independent extrauterine life. This is also known as the miscarriages. Prevalence of the women with genital mutilation also need to be understood. The proportion of the women interviewed in a community survey who report having undergone genital mutilation. Female genital mutilation, that is FGM, is the result of all procedures that involve the partial or total removal of the external female genitalia or other injuries to the female genital organs, whether for any cultural or any other non-therapeutic reason. Data sources include community surveys or census questionnaires. Repeated surveys would be able to detect the trend. Inclusion of the women in the age group of 15 to 49 years is preferred. Data can be disaggregated into age, residence and ethnic groups. This indicator provides the baseline information for the policymakers and can be helpful in evaluating the subsequent monitoring and evaluation. This indicator is correlated with the reproductive health. Women may not feel comfortable to reveal the information. Sometimes FGM is performed on the babies, and in those situations, women may not be aware that they have undergone the FGM and also about the type of FGM has been performed. This indicator may not be useful where FGM is not practiced. Definitions are not universal, and representativeness of this measure depends on the representativeness of the sample used and the willingness of the women to respond to the questions on FGM. Now let's have a look at the prevalence of infertility among the women. The proportion of the women of the reproductive age of 15 to 49 years who are at the risk of becoming pregnant, not pregnant, sexually active, not using contraceptions and not lactating, who report trying for a pregnancy for 2 years or more. Women of reproductive age refers to all women aged 15 to 49 years of age. Women at risk of becoming the pregnant refer to those who are not pregnant, sexually active, not using contraception and not lactating. The sources of the data for such kind of information are community and health surveys. In community surveys, couples answer the detail on sexual practices, contraceptive use, previous birth and lactation. There is a need to identify the difference between involuntary or voluntary childlessness in the health surveys. Data is disaggregated into age, ever been pregnant and length of the time trying for the pregnancy. This indicator assesses the level of infertility in a community. The causes of the infertility are genital tract infection, congenital error of the reproduction and hormonal factors. Secondary infertility is caused by the complications and sequelae following the sexually transmitted diseases. Level of the secondary infertility can serve as the surrogate marker for long-term sequel of sexually transmitted infections. There is often a chance of misclassifying the early pregnancy loss as no pregnancy. There are many reported incidents of the urethritis in the men. The proportion of the men aged 15 to 49 years interviewed in our community surveys who reported having one or more episodes of urethritis in the previous 12 months. Urethritis is discharge from the penis with or without a burning sensation or pain while passing the urine. Community surveys are used for collecting this data. A two-stage cluster sampling technique with a 12-month recall period is used. Survey areas proportional to the size in the first stage and in the second stage, households with the probability inversely proportional to the area size are selected. Men of 15 to 49 years are interviewed to know the prevalence of urethritis. Data is collected in private, assuring that their data will not be made public. Data is disaggregated into age, residence and geographical area. This indicator is useful to assess the burden of STI in the adult male population and also to study the impact of preventive services for STI. Self-reported symptoms should be interpreted with caution in assessing the impact of preventive and treatment services according to WHO 2006. Now let's have a look at the prevalence of HIV infection in the pregnant women. The proportion of the blood sample taken from the women aged 15 to 24 years that test positive for the HIV during the routine sentinel surveillance of selected antenatal clinics. Positive HIV test is the one where a sample is considered positive when on the single application of the test, evidence of the past HIV infection is determined. This standard screening test for HIV is enzyme-linked immunoabsorbent assay. The source of the data are sentinel surveillance and population-based seroprevalence. Sentinel surveillance identifies HIV infection from the blood of the person given for other purpose in specific settings that provide services to them. These specific settings include blood banks, sexually transmitted infection clinics, military recruitment programs, and antenatal clinics. The data from these settings may not be representative of the general population. Household surveys cover large population but cost intensive. In both the settings, requirement of the informed consent introduce non-participation bias. Data is presented in terms of age, occupation, mobility, and residence. Representation of the males in sentinel data should be increased as evidence shows higher infection rate among females than males. Sentinel surveillance is useful to monitor the trend in 15 to 24 years and may not have utility in assessing the trend in incidence and prevalence of HIV in adult population. Let's have a look at the knowledge of HIV related prevalence practices. The percentage of the survey respondents who correctly identify all three major ways of preventing sexual transmission of the HIV and who also reject all three major misconceptions about HIV transmission or prevention. Inclusion criteria include all aged 15 to 49 years and only those who satisfy the definitions for complete knowledge and lack of misconceptions in the numerator. Most of the data from developing countries on knowledge of the HIV prevention were obtained using the demographic and the health surveys. For getting estimates, samples should be designed to represent the group of the interest such as male, female, urban, rural, people of different socioeconomic status and adolescents. Misinformation dimension is added to this indicator to exercise the discrimination in identifying individuals and population who are susceptible to adopting behavior that modify the chance of HIV transmission. Questions used in the survey should be validated in different language and culture context. If youth is the priority, the school-going adolescent should be included if knowledge on HIV transmission is sought. Then, along with the knowledge assessment, the trend in the indicators of the behavior should be included according to WHO. There is a need to know the obstetric history of the women. The obstetric history is taken into consideration at the diagnosis. It assesses the health risk of the patients and to prepare the management plan. A comprehensive history is recorded at the time of pregnancy, evaluation, or at the initial antenatal visit. The details collected from these are the identification data. It consists of details like patient name, age, ethnic group, gravida, parity, last normal menstrual period, expected date of delivery, and gestational age. Gravid means number of pregnancies. Parity refers the outcome of pregnancies. The chief complaints describes the symptoms or problems for which the patient came to see the doctor. The history of presenting the illness need to be understood. The onset, nature, aggravating or relieving factors of complaint are discussed with the patient by the doctor. The history of the present pregnancy need to be taken into consideration. The details from the diagnosis of present pregnancy to the onset of complaints are inquired and recorded. There is a need to take the past obstetric history as well, under which the details of previous pregnancy in chronological order are recorded. The information on the following details is inquired to assess the possibility of occurrence of the previous problem in the present pregnancies, which include the gynecological history is the history of intermenstrual bleeding, menorrhea or dysmenorrhea, sepsis or sexually transmitted diseases, and cervical smear test results are inquired. The contraceptive history should be understood. History of the oral contraceptive and intrauterine devices usage is inquired. Their usage has been shown to cause the pregnancy loss, birth defect, infections and premature delivery. The medical history, which means presence of the disorders like the diabetes, hypertension and renal disease, is inquired as they will affect the pregnancy outcome. The surgical history. If patient has undergone a surgery, the details like the date, hospital, surgeon and complications are recorded. The social history also need to be taken into consideration, or the history of the alcoholism, smoking, substance abuse are recorded and managed. Contact or exposure to the animals is also recorded. The drug and the allergy history, that is allergy to the food and modifications, are inquired in order to avoid their exposure. Drug intake is also recorded. Family history, where patients are asked on the history of the congenital abnormalities, hypertension, diabetes and tuberculosis in their family member, are documented as they are passed on to the patients, putting them at high risk to develop the same problem during the pregnancy. Systemic reviews include the symptoms experienced by the patient during the pregnancy in their body system, such as cardiovascular, respiratory, gastrointestinal, urinary, nervous system, musculoskeletal and dermatological, which are inquired and recorded. Now let's summarize the module. We have understood so far that reproductive health is a state of complete physical, mental and social well-being and not merely the absence of disease or infirmity in all matters relating to the reproductive system and to its function and processes. Scope of the reproductive health range involve information, education and communication, special services to the adolescents, discouraging the practices like the genital mutilation, prevention of the gender violence and sexually transmitted diseases, termination of unwanted pregnancies and promotion of safe motherhood and family planning programs. Millennium Summit in year 2000 set 8 Millennium Development Goal, that is MDG. The 5th goal advocated reduction of the maternal mortality, achievement of the universal access to reproductive health care. Various international organizations have consented for 17 reproductive health goals, and they are total fertility rate, contraceptive prevalence, maternal mortality ratio, antenatal care coverage, birth attended by the skilled health personnel, availability of basic essential obstetric care and availability of comprehensive essential obstetric care, perinatal mortality rate, prevalence of low birth weight, prevalence of positive syphilis, serology in pregnant women, prevalence of anemia in women, percentage of obstetric and gynecological admissions owing to abortion, reported prevalence of women with genital mutilation, prevalence of infertility in the women, reported incidence of urethritis in the men, prevalence of HIV infection in pregnant women and knowledge of HIV related preventive practices. Thank you.